Welcome back to the KDPG Sunday edition. This morning we're talking about the proposed closing of Mayview State Hospital, Allegheny County's only remaining state hospital to provide comprehensive care for people with mental illnesses. This week, the state of Pennsylvania announced plans to shut down Mayview by the end of 2008. Back with us this morning is Dan Torisky, the president of the Autism Society of Pittsburgh, whose son, a 50-year-old autistic son, Eddie, spent much of his earlier life at Western Center, another state hospital in Cecil Township in Washington County that closed in the year 2000. Joining us now is Dr. Jim Jacobson, the medical director of Mercy Behavioral Health and the chairman of psychiatry at Mercy Hospital of Pittsburgh. Doctor, thank you so much for joining us.
Thank you.
Well, I already asked this question before. I will ask you. The kinds of patients who are at Mayview right now, can they be allowed to be, allowed is the word, into the community?
Well, absolutely. Certainly, we've had downsizings before at Mayview. We've accepted at Mercy Behavioral Health, and other providers have accepted people coming out of Mayview, and we could do a really nice job in the community. But the real key issue, which has been mentioned here, is the money. We need to hire the staff. We need to develop the programs. And that takes money, and as what was said before, promises were made in the past that weren't always kept, and we really need a commitment to have the finances, and then we could develop programs that do the good job.
Do you think, both of you, do you think many family members will welcome back some of the people who are at Mayview, and maybe that will, how will that play out?
We need to have an individual plan, for every single person there, and it's so varied. Some may go back to family. Many, I think, will be in group homes or other types of residences, personal care homes, and so forth. So it really depends on each different individual. I think many people may end up in other types of residences.
How would a person be admitted to Mayview as it stands right now? Does that go through the family, or does it go through the doctor? Does it go through the state, the courts? How is that done? Because the point being that if Mayview is closed and there are people who need some sort of assistance, who's going to make that decision from that point on?
Well, what happens right now is usually someone gets admitted to an acute hospital, be it Mercy Hospital, Western Psych, acute psychiatric hospital. And in most cases, people get stabilized relatively briefly in a week or two or so. But sometimes more time is needed, and that's what we've used the state hospitals for, people who need additional time. And this is a big concern for the acute hospitals in terms of having availability, having accessibility for people with acute problems. We have people who need more time in the acute hospitals. That takes away beds for other people who need the same help.
Would you agree with that assessment?
Oh, yeah. If it wasn't for Western Center, for example, when my son was 11 and threatening his sisters and his brother and his mother, we put him in Western. He was there 5 days a week, home every weekend, where we concentrated on him, and as a result, I had a normal family for 5 days a week. I was able to accept Eddie on the weekends, and as a result, I have 3 PhDs in the field today and a very solid family. No, the man's right. If there are the supports out there and enough money to follow along and people to follow with them, including the people who are working at Western now or working at Mayview now, to stay with these people and monitor, and if the funding is there in perpetuity and doesn't go down a rat hole after a couple of years, I think it can be done.
We have programs in place now. We have crisis services, case management, other programs, clinicians that have worked very much well with patients coming out of Mayview. So we do need additional resources because of the people who are there now are people who haven't been able to come out previously. So unfortunately, we have some sick individuals who need the resources.
How has it changed in treatment over the years? Are we looking at people having to use medication if they're released from Mayview, or what's the standard form of treatment right now?
Well, a combination of things. Medication, of course, is critical, and that's what led back in the 50s to the original first wave of people coming out of the institutions. And medications keep improving, and that's real key. In addition, the other clinical services, case management services, and recently we've come into what we call a recovery model, where we've changed the philosophy, looking at the person and having them really giving them ownership, working with the whole treatment team to develop the best course of action. And people have changed their thinking on how to work with individuals with mental illness, and it's definitely improved over the years.
You know, as you say, deinstitutionalization is more than a half a century old. the last great wave of this was in the 1980s, I suppose. What did we learn from that period that we can apply here as we face this with Mayview?
Big issue, as what was discussed, is the money.
Yeah.
We have people with the expertise. The community is actually a great place for people to be better integrated and to have better freedom and good treatment. It's not to say Mayview's done a fantastic job, but what we've learned from the past is that we need the money not only up front to develop the programs, but ongoing. In the early 90s.
What do these programs do?
Well, key is to have people live healthy, happy lives, be part of the community, keep people out of the hospital, and have people enjoy their lives like anybody else. People need to live a life that's functional and be part of the community, and that's one thing you don't see if you're living in an institution.
Well, that's easy to be said, and Andy's report at the beginning of the program also revealed that a lot of people end up not necessarily making it in the community, and they end up being homeless and probably not getting the medication they need, and then they do fall through the safety net, if there is one.
You have to understand that the operational word is appropriate. What people want people to be and the happiness they want them to have, you can't say be happy, live in this house and be happy. You have to have examples of how they can be happy, the training, how to deal with the complexities of society, how to act appropriately in certain situations. Medication helps, nutrition helps, the approaches that Dr. Jacobson lays on people help. Mike Doyle, our congressman, said in the New York Times in about 13, 14 years ago when this frenzy to close institutions first hit, he says there's no reason why the public institution or large residential facility can't work with the private sector so that it's a two-way street always, back and forth, from the community and back for more training and back out again, in order to better serve everybody more economically with greater savings in human suffering, as well as money. And it can be done, but the operational word, appropriate. Not what you want for somebody, but what they're able to accommodate.
What about the stigma in the community? I mean, very few people are necessarily going to want to have a center next to their home. If, we're talking about you want residential communities for people.
Certainly, the not in my backyard syndrome is always an issue. But usually in the community we're dealing with smaller residentials, although it varies. I mean, from apartments to larger sites. But I think everyone has someone in their family, if not their immediate family or extended family, that's had mental illness or mental retardation or autism. So it's not something that's totally foreign. Right now it's happening in the community. Not everybody's aware of it, but we do have residentials out there. We've done a great job with keeping people in treatment, and we have different programs now where we go out to people out in the community. We have physicians that go out with other team members, nurses and social workers. So we've over the last 10 years or so, we've really changed some of the models. We can really work with these people out in the community. We need the money to make it work.
Dr. Jacobson, from where you sit at Mercy, is the Mayview development a crisis or an opportunity?
I think it's an opportunity. It's an opportunity to do more in the community, to improve the lives of these people afflicted with mental illness. So I see it as an opportunity. But I'm concerned, and many people are concerned, that we need to have a commitment to have the resources to do it.
That's right.
What about the forensic side of closing Mayview? Does this pose a problem, or is it just, you've got to smile?
The forensic side, I don't know what's at Torrance. I do know they need the same kind of habilitative work in a more closely supervised situation. We know quite a few come across our table, and it's ongoing. It can, sometimes it's, well, most of the time, it's a lifetime commitment you have to make to care for these people and to ensure that they don't hurt themselves or somebody else.
Gentlemen, thank you so much for being with us this morning on the KDPG Sunday edition. David and I'll be back with some final thoughts in just a moment.